That's lovely. So, hi everybody. Welcome to today's Lunch and Learn. We've got Magda and Lynn. I'll let them introduce themselves in a minute. And they're going to be talking about dementia risk in minoritized ethnic groups, incidence and 12 modifiable risk factors. So there'll be time for questions at the end. And if you could keep yourself on mute, that'll be great. I'll also put the links in the chat to our ARC website, our YouTube channel, and our newsletter, because the recorded versions of this will go on all of those things. So I'll pass over now to Magda and Lynn.
Hello,
Thank you.
everybody.
Go.
So I will start and then I'll pass on to Lynn. So let me just put my presentation on, share it with you. Is that visible for everybody? Yeah.
Yeah.
Okay, so let me just introduce myself. I'm Magda Jourdain. At the moment, I am working as a lecturer in psychology in Leeds Beckett University, but until a month ago, I was working in the Bradford Institute for Health Research and integrated in the ARC, funded by the ARC, and working in this area of dementia risk factors for minoritized ethnic groups in the UK. And the work that we did was focused on identifying research gaps and priorities. So this is what I'm going to talk about today. This was work that was funded by the NIHR and also by the Alzheimer's Society, because it was part of a postdoctoral dementia fellowship. And just a usual disclaimer that obviously these are our views and not the views of our funders. So the background for the research that we developed is focused on evidence that in the general population, it is possible to prevent or delay up to 40% of dementia cases by reducing 12 modifiable risk factors. And these include factors like smoking, obesity, hypertension, etc. And at the same time, we also know that dementia does not affect all equally. There is evidence in the literature that for people from minoritized ethnic groups, that is a higher incidence of dementia. There are more cases of early onset vascular dementia. And there are also more health inequities that contribute to an increased risk in these modifiable risk factors. However, it's not very clear how the risk associated with these modifiable risk factors maps on into people from minoritized ethnic groups. And that is because the evidence is based on the general population and not on specific groups, because these groups have not been consistently included in this area of research. So what we wanted to do was to map what is it that we know, what is out there, what do we know from the research, and importantly, what are the gaps and what should be our priorities going forward for the projects that we would like to develop in this area. So we developed three main research questions, more specific questions. The first one was focused on the WHO, which minoritized ethnic groups have actually been researched. For which of these 12 modifiable risk factors, and which methods have been used. And we were interested in mapping out possible shortcomings of these methods, and obviously from there also develop more suitable approaches. So to answer our questions, we developed two main strands of work. The first one was focused on reviewing the literature. We used a scoping review methodology, which is a kind of evidence synthesis where what we are trying to do is really to map out the research area to have a picture of what's out there. So we are not synthesizing a specific effect. We are just focusing on mapping out that research area. So we developed a protocol, which we registered. So there's quite a lot of detail that goes into this. But today I just wanted to give you an idea of the kind of studies that we were trying to find and capture and summarize. So these were studies that included at least one minoritized ethnic group, and they were studies that were focused on the association between at least one of these 12 modifiable risk factors and dementia, or cognitive decline, which is related to dementia. So our focus was this association, not the modifiable risk factor just on its own, but its association with dementia. And we were focusing on the UK context. We also developed at the same time patient and public involvement and knowledge user engagement activities. We talked to people from the African Caribbean, Bangladeshi, and Ukrainian communities, and also with health and social care professionals. And as you might imagine, there's quite a lot of things that we talked about, lots of things came up. So I'm just going to highlight 3 main points. The first one is about context. People really emphasize how important it was to take into account the kind of services that people had available around them when we were thinking about the risk and its impact on dementia. And this was one of the main reasons why we decided to specifically focus on the UK context instead of just going global, because there was this likelihood that we would be looking into very different things and not really being able to discern what was going on. So we focused on the UK context, specifically following on from all PPI activities. Another thing that people talked about quite a lot was the interaction between risk factors. Very often, one of the first things people would say would be, you can't just focus on one. This is kind of a quote of one of the people involved. There is a thread running through, and they would explain, from their experience, how, when someone maybe is feeling a bit low or is depressed, they're not going to want to go and have physical activity or meet other people. And so they were kind of making the links between the risk factors, which is very interesting because in the literature, very often from this background search we had done, we could see that there was much more of a focus on isolating the specific contribution of each one of the risk factors instead of looking into the interaction. So what we did with this particular point that was raised by the PPI members was to include this in our mapping. So we specifically looked in our studies for studies that were looking into the interaction between risk factors, and this is something that we mapped to. And people also talked about other risk factors, like racism, discrimination, deprivation, and they reinforced the importance of considering them. So what we did was we also mapped these other risk factors and their interaction with the modifiable risk factors that had been identified before. These are our results. This is a depiction of our search. It's a lot of information, but I just wanted to show you that we looked into several different databases. We looked into the grey literature. It was quite a thorough search. And in the end, we found 14 studies, which included 20 reports. And now moving to our questions. The first one, which minoritized ethnic groups have been researched? As you can see here, most of the studies were focusing on South Asian communities and Black or African Caribbean communities. These were the categories used by the authors of the studies. And one of the things we can see is that the ethnic groups that are used are quite broad. The categories are quite broad, even though we know from other literature that focusing on more specific minoritized ethnic groups is quite important. We don't see that happening here. And even when you have some categories that are a little bit more specific, sometimes these categories are included in the initial sample and they are described in the initial sample, but later on in the analysis, you don't have results available about the specific groups, either because the groups have been merged for the analysis to have more power, or because the analysis focused on the interaction of ethnicity with other factors instead of looking into the different subgroups in terms of ethnicity. Moving on to the what were these 12 modifiable risk factors? Which one of them were looked at? You can see here the number of studies where the different risk factors had been analyzed either as predictors or controlled. The ones that were more often looked at, as you can see at the bottom of the graph, are diabetes and hypertension, while low social contact and air pollution were the least looked at risk factors. And one thing that was interesting to highlight is that actually, from what we know from the general population, low social contact and air pollution actually have the potential to contribute twice as much to dementia compared to diabetes and hypertension. So we can be sure that this applies to minoritized ethnic groups, because this is evidence that has been generated in the general population, but it's a good indication that there are good reasons to focus more on these modifiable risk factors like low social contact and air pollution that have not been looked at as often. In terms of the interaction between risk factors, which was mentioned by the PPI, we only found 2 studies looking into this. And we found 0 studies looking into the possible impact of racism or discrimination on the relationship, on the association between modifiable risk factors and dementia. And now moving on to the methods. In terms of how ethnicity was measured, we found most of the times there was a reliance on medical records and also the UK census categories being used. For the risk factors, we noticed that most times risk factors were measured in a dichotomous way. Hypertension, has the person been diagnosed with it or not? Instead of having a specific measure that could give you some sense of the severity of some of the conditions. So this was rarely available. And we also found variation in the criteria and sources for the different risk factors. Even something that might seem quite straightforward, like low education, was defined in various different ways in different studies, which means that, to put evidence together in this area at the moment would have been very, very difficult, very unreliable. In terms of outcomes, most of the studies used a dementia diagnosis with or without cognitive assessment, and most of the times these were based on medical records. Sometimes some studies used a cognitive assessment. They actually assessed people, but they never had an external validated cutoff to say this person actually has cognitive decline. In terms of recruitment, there were 9 studies that were focused on a specific study location, and 8 of those studies were focused in London. So moving on to what we think are the main highlights in terms of gaps and priorities and directions for the future. Starting with the WHO, what we notice is this lack of specific ethnic categories being used in this kind of research. My colleague Lynn will talk about the attempt to do this in the Connected Bradford database, but we didn't find examples of actually using more specific ethnic groups, and also a lack of variability in terms of the areas of the country where research is been carried out. So as you saw, most of the research which was specific was focused in London, even though obviously we have minoritized ethnic groups and very diverse communities in Bradford and other parts of the country. So here the focus in terms of having these more specific ethnic groups has to be recruitment. How do we actually act in a purposeful way to reach these people and to build these relationships and make recruitment with these communities possible? And our PPI members talked about this, and they really emphasized the importance of long-term community collaboration and appropriate funding in this area. So nothing new, but another area in which this seems to be very important to support research and to go forward. In terms of the methods of how we are conducting this research, we found an increasing trend to rely on medical records, which on one side, obviously, has the advantage of providing more data, maybe people we wouldn't be able to reach otherwise, but with using outcomes like a dementia diagnosis recorded in the medical records, this can lead to some biases, specifically with people from minoritized ethnic groups, because we know they have more difficulty accessing services, getting a diagnosis. So it's quite likely that there would be underestimation of risk based on medical records. And then with ethnicity, we know there are problems with using more specific ethnic groups based on the medical records too. So we already know what the problems are with the medical records. Basically, there are already recommendations, but there seems like it would be very important for this area of research to look into how we could implement some of the recommendations to improve medical records that are already out there. Also, we found that it would be very important to develop cognitive measures which are specific for the diverse communities, because as I mentioned before, we found cognitive assessments that didn't really have validated tools, and to develop an agreement on risk factors measures, which were very diverse from study to study. And finally, in terms of the topics of research, we found lots of gaps. So the first one, which was quite a striking difference between the PPI contribution and what we found in the literature, is this lack of research around the interaction between risk factors, which seems to be so important when we know that people often will have more than one risk factor at a time, and it would be so important to know where to start. Are there causal relationships between the risk factors? Are there clusters of risk factors that we should pay particular attention to in terms of clinical priority? So this is an area to explore that could have a big impact in terms of clinical prioritization and going forward with personalized risk reduction strategies. In terms of risk severity, there's also very little that we know, and it would be very important also to prioritize interventions and other things like social isolation and discrimination. Discrimination in particular, it's an area that has been explored in the US, for example, but we didn't find anything on that here. So it seems like a very important gap to explore. So this is just our summary, and I would like to acknowledge all the members of the team and also the ARC support, and in particular, the Ethnic Minority and Research Inclusion Network, which supported me through the reverse mentoring scheme. And I will pass on the presentation to my colleague, Lynn.
Thank you, Magda. That's a really nice sharing. And now I'd like to share my screen. I hope you can see my slides as well. Let me from the beginning. Thank you. So thank you. So just a little bit introduction about myself. My name is Lin Gong, and I'm currently a research fellow funded by NIHR ARC Fellowship based in University of Leeds, and also BRHR, the Bradford Institution for Health Research. And I'm also a research team, joined a research team of the scoping review Magda just shared. And from that scoping review, we found out like that is really important findings or very interesting findings that when we look into the ethnic minority groups, we found out like there is a lack of evidence to know the more like the specific information or a more detailed picture about them. This also reminds me when we both joined an academic conference before, they talk about the dementia research, but we ask a question like dementia research for whom? So I think that is the area we both look into because we want to know like who is the target population before we move on to the conversation like dementia intervention for the people who in need. So yeah, so this research I'm gonna to talk a little bit more about is based on our research findings from the scoping review, and also a very valuable data set which allow us to try to fill the current research gap in this area. And more importantly, we feel like this is very important to raise our awareness to look into a more specific group, try to zoom in the picture about the ethnic minorities. Yeah, as the title can be seen from here, we will look into, in this study, we will look into the dementia diagnosis rates for different ethnic minority groups and using the primary care data based in Bradford. And just a little bit background, well, the number of people living with dementia is still increasing. And while as one of the recent statistics shows, like by the end of 2051, there will be the number of people living with dementia will doubled. And meanwhile, when we look into the evidence, we found out like when they come to the dementia research, current research merely focusing on like a white group or black group or a more generally broad category of the groups. So the evidence about the ethnic minority specific group is lacking. But this is definitely important information we need to know when we want to more understand the picture about the dementia. And here I just show a table showing that how the previous research using the category. So most of the study has been using, like, for example, Asian, British, Black or mixed group, other group, white main population, and unknown group. And meanwhile, actually in the NHS ethnicity codes, they can find more detailed information to record ethnicity information. And since the 2011, the census category has been updated. One of the main change is to move the Chinese from the other ethnic group. And by 2021, as we can see here, we like the census already adopt quite specific detailed information about ethnicity, and most of the and the NHS ethnicity records has been in line with the census category and restored this information. However, if you simply group the whole like all the group into one big category, you will miss some of the informations, like for people from East Asia or South Asia, or the main Black group people from the Black Caribbean or Black Africa. So in our study, we use the SINOMAT code, which is like a medical record. So you can extract the information, the record from the primary care data set. So quite specifically, we got 35 different concept ID. And what we do, we need to do some data cleaning, we need to do some regroup. But meanwhile, we don't want to miss the information, the detailed information. So considering the sample of the number of the sample in our research, meanwhile, considering our research purpose is looking into the detailed information about each ethnic groups. So we ended up using the detailed information from our data set to look into the dementia diagnosis for 7, including the white age groups in the UK. So I like to give a little bit more information about the data source, since I think Bradford, the connected Bradford is shows a really good example that they can combine the data from the different source. So centered on one person, you can keep the record, the routine record of like primary care, secondary care, or social care records. And meanwhile, based on this person's, like, for example, postcode, you can know the region or the regional level of deprivation, or like the education and also housing condition for that person. So this together, those information would be very valuable for us to conduct more the research, to figure out and more information and to understand like what is the specific information or story of this person, and so we can know more or generate more target-oriented intervention. So this data set called C. Bradford has the detailed health data record, and also the non-health data record, which allow us to look into the detailed ethnicity, and even some of the non-health data is the regional level air pollution. And this is one of the modifiable risk factors as already identified in current research. So in this data set, we can that allows us to look into more detailed information for each ethnic minority groups. And I think this table one allow us to have more, shows a good example like the detailed information for the research sample in this study and by the 8 ethnic minority groups. And overall, we got 289,000 sample in this study. And based on our category of the different ethnic minority groups, we can see that we got a quite good mixed population there with which shows inequity of the health condition and also the different numbers for each group. And the number is quite enough for us to conduct the further research as well. And for this demographic characteristics table, one of the very interesting information or very detailed information is allow us to see that like for example, if we use the index of multiple differentiation to understand where the people come from, we can see that most of the white population lives in the number 1, which means a higher level of index of multiple differentiation, lives in the level 1 area. And by comparison, other or most of the people from ethnic minority groups such as South Asian and the Black Caribbean and are living, the majority of them are living in the most deprived areas. And from the detailed information already give us a clue that if we want to look into the details about the inequity among the different groups. And we use the SynOmed code to find people who are diagnosed with dementia and cognitive impairment. And the research period is from 2009 to 2019. And within the overall 10 years, we compared the dementia incidence among the group. And by using the white British as the reference group, we can see that for each of the group, they have reported a quite different variety of the dementia incidence. But if we in previous research, if we mix them up, it may lead to a biased results, because if by comparison we can see that the people from the Asia British, specifically from the East Asia, they've reported a relatively lower rate of dementia incidence. And however, the people from the South Asia sub-ethnic minority group, they have been reported a higher dementia incidence group, even higher than the white British. And the same difference can be observed in the Black British population. And we further checked the relatively ratio among the groups by comparing to the white population. And the results shows that among the Asian British, the dementia incidence for the South Asia was 35 higher than that of the white British. And the similar higher risk was observed in the Black Caribbean. And however, by comparison, the current records shows that the people from East Asia and the Black Caribbean have reported a lower incidence of diagnosis of dementia. And meanwhile, we noticed that the results for the Black African is very low compared to the white group. And we think in a way we need to be very careful to explain the result. Meanwhile, this also draws our attention for future research to better understand or dig out why the diagnosis rate is low for Black African, and this could be caused by maybe the reality that this specific group of people, they may have dementia but not diagnosed timely, or there is a lack of informal diagnosis for this specific group. So a lot of research could be built based on the results by applying a more specific ethnicity category. And I like to also show some of the results among the group, as we can see the difference here. So this figure shows the mean age of dementia diagnosed among the 8 groups. So by comparing to the white group, which the mean age of the dementia diagnosed is 69.5 years old, around 17 years old. And then if you compare or look into the other ethnic minority groups, they were diagnosed in a relatively younger age, which means they are at the risk of early onset dementia as well. And this figure also shows that by comparing to the white group as the reference group, after they get diagnosed with dementia, the main age at death for ethnic minority groups is relatively younger as well. And behind these numbers, we can do a lot of research to understand maybe possibly this could be cause of the lack of care, lack of information, and from the age difference, you can see it is from the for the South Asia group, it's around 4 years earlier died before the white group. So what can we do for this and to delay the age of diagnosis or to delay the main age of death? So based on these results, that just give us a more evidence and more picture to know and understand more for the specific group. Yeah. And here comes to some highlights about this study. So overall, from the current results from this State Bradford data set, we found out that dementia incidence and prevalence has been rising over the past 10 years, and it's significantly higher in South Asia patients compared to the white British, but lower in East Asia and Black African. And also people from the minority ethnic groups were diagnosed at a younger age and died at a younger age too. And for the lower incidence and prevalence for the Black African group, we highlight or we draw the attention to the possible under-recording of the dementia in this specific group due to the possible barriers to dementia diagnosis. And since we have a section for Q&A, so I listed some like keywords or key points for myself to reflect in my research, and also open to discussion or yeah. So first one, behind this, the results we found out here, we're thinking that behind for each ethnic minority groups, maybe they may bear the different risk factor, a dementia risk burden for the dementia. So we should definitely look into more the details, because existing evidence already show that, for example, for Black British, they are already under a higher risk of hypertension or diabetes. And from the PPI work Magda have done before, they've already mentioned the social isolation and also the interaction effect among the 12 modifiable risk factors. However, the research need more evidence and look into those details, and based on the more detailed data and based on the more research efforts to found the evidence for this research questions. And also one of the highlight from our findings is the barriers for the formal diagnosis for the ethnic minority groups. This could be because of the lack of education or the lack of information. And also, and in the end, we want to highlight that among the 12 risk factors, it's good for us individuals to understand and try to reduce the information, to reduce the risk factors to prevent dementia. Meanwhile, we want to mention that this is not only the individual level burden, so the community could do more and social policy could do more, and the public awareness and education should bring the more awareness like to the regional level deprivation, and also bring the awareness to the ethnic minority related inequity in this area in order to have more effective intervention, because that is what we want to do and to better helping people who are living with dementia. So if you want to follow the research, feel free to follow us and also the website. And I think that's it. Thank you for listening. Thank you.
That's great. Thank you, Magda and Lynn. That was really, really interesting. And we've actually got a question in the chat from Sabia. She's put, was there any difference in diagnosis age between men and women?
Yeah, thank you. According to previous research, there is a slightly difference between men and women. And in our research, I didn't put that into our figure. The women shows slightly higher risk than the men about the dementia diagnosis. And with the same data source, we are gonna look into more details like the different gender group, different age group as well. And to like this study, we want to zoom in the picture and in order to help us understand more before we take any actions, before we go into the conversation about the intervention for them or better support for them. That's a really good question. Thank you.
Thanks very much. Just wondering if Sabia's got any other questions that she wants to ask while she's here. Or Magda, have you got any questions for Lynn? And Lynn, have you got any questions for Magda?
Sorry, that was really, really interesting. I'm sorry, I've got a very sore throat, so I was going to try and feel tight. But so I think one of the questions I had while I was listening to that was, is there any research, or will any of this research cover the reasons why there might be sort of higher hypertension or diabetes or social what's the word
Yeah.
exclusion in
Yes.
ethnic minorities than say the white population?
Yeah, Magda, do you want to cover that? I can add something more later. According to the scoping review.
Yeah, that's an interesting question. I mean, obviously, it can be approached in many different ways. The one way that we saw that being approached in the scoping review is on the relationship between deprivation and the modifiable risk factors. So the idea that the fact that people live in some deprived areas might have an impact on the rates of hypertension, the rates of diabetes, etc., because of the effects of poverty, because of the effects of housing, etc. So that's one of the ways in which that has been considered, but the kind of research we were reviewing in the scoping review was more focused on epidemiology. So what they were doing in practice was they were trying to control for the impact of deprivation. They were not exploring, how is it that this actually takes place, and probably that would be actually more suited to a more qualitative approach. And I think that is something that probably from this research we would like to take on board to understand a bit more about what actually happens if someone is in this high risk situation. What are the factors that are contributing to that? And some of them might have to do with the fact that the person is part of this minoritized ethnic group, and that has to do with having more difficulty accessing certain aspects of healthcare, accessing certain jobs, etc. But I think from this broad epidemiological perspective, it's very difficult to capture those details. So I think we would need to move on to actually talking to people, follow people that have different kinds of profiles to start to get a better idea about how these things contribute to the risk factors, and then the risk factors impacting dementia. So I would see this developing more in that qualitative way. And obviously then from there, we can develop hypotheses and test them with, with the databases that we have. But I just, my experience carrying out this scoping review is just that we're not at the point yet where we are really kind of trying to reflect and think about how these things are connected to each other. We've been spending a lot of time to try to actually show this risk factor has this specific contribution, which is important and understandable, but I think it will require this next step to actually tackle the kind of questions that you are suggesting.
Yeah, thank you for the question. I'd like to add in a little bit sauce here, because I think one of the very valuable of our research looking into ethnicity difference is that the ethnicity could link to a very broad, like social aspect, culture aspect, or lifestyle aspect for each ethnic minority groups. So these factors may like shape people's like daily life, or what they eat, their diet, and doing exercise, the culture. So those may linked to the good good lifestyle habits that could be reduce the dementia risk factors, or this could lead to a relatively for example, the unhealthy diet, which may lead to the exercise or diabetes or hypertension. So what I want to say is that the ethnicity shows a good perspective for us to differentiate the different group, to understand their life story and their situation, and from there maybe also provide us a good perspective to understand the different risk factors they're bearing, and why there is a difference for different ethnic minority groups. Thank you.
Yeah, and I was just going to add that for some of the risk factors, there is research going on, for example, diabetes, trying to find out if there is kind of a biological component to it. We have not reviewed their literature specifically, but as far as I know, there's still a lot of uncertainty in that area. Some studies point out, oh yes, there might be this more kind of biological, genetic, whatever it is, especially in diabetes in people from a South Asian origin. But then you also have contradictory evidence. So there is also some more biological aspects that have been looked at and are being looked at, but the evidence, as far as I know, is also not very strong. And then you have all these other social aspects that haven't been looked into in the area of dementia as much.
Yeah.
That's fantastic. Thanks both. I think, Zobia, your questions have been answered there, unless you've got any other ones.
Thank you.
Oh, lovely. That's great. Yes, Zobia said yes, brilliant. So we'll save her throat. So thanks ever so much, Magda and Lynn. That was a really good session.